everyone, and welcome to Talk Nerdy. Today is Monday, February 13th, 2023, and I'm the host of the show, Cara Santa Maria. Happy Valentine's. That would be tomorrow. Galentine's. Better, I think. I hope you are celebrating and that you are making the best of whatever situation you may find yourself in. And, you know, I always write at the top of the show, want to thank my patrons. I never want to leave you out. It's because I really do rely on you to make this show possible. You'll see that this week I don't have any host-read ads. I only have the programmatic ads added to the show after the fact, which barely make money compared to the host-read ads. So I really do rely on the support from individuals just like you to make the show go each week. If you don't want to hear the ads at all you've got to do is subscribe, subscribe to be a patron, and you will find access to ad-free episodes each week. My top patrons this week include Daniel Lang, David J.E. Smith, Mary Neva, Brian Holden, David Compton, Gabrielle F. Jaramillo Gonzalez, Joe Wilkinson, Pasquale Gelati, Ulrika Hagman, and so many more of you. Thank you all so much for your support each and every week. All right, let's talk brains. So this week I had the opportunity to chat with Dr. Sara Manning Peskin. She's an assistant professor of clinical neurology at the University of Pennsylvania. She specializes in cognitive and behavioral neurology. We're going to talk an awful lot about dementia today because it's fascinating to me, but we're also going to talk about some kind of curious and bizarre and fascinating neurological disorders that she highlights in her new book. It's called A Molecule Away from Madness, Tales of the Hijacked Brain. So without any further ado, here she is, Dr. Sara Manning Peskin. Well, Sara, thank you so much for joining me today.
Thanks so much for having me.
So I'm excited to talk about your book, A Molecule Away from Madness, Tales of the Hijacked Brain. And of course, this has been out in hardcover for about a year now, but the paperback is about to drop. Is this your first book?
It's my first book.
It's your first book, and you were longlisted for the Penn E.O. Wilson Literary Science Writing Award. That's amazing.
Oh, thanks. I was excited.
That's so exciting. And so have you always been involved in science communication and you just wanted to sort of make it more long form, or was this whole endeavor new to you coming from medicine and neurology and now working into translating it for the public?
I came to writing pretty late, actually. So I started off in, they have these combined programs where you can do a PhD and a medical degree sort of in one. And I started medical school and enjoyed it. And then I went off to try to do my PhD and just realized it was not at all what I wanted to be doing. So I went back to medical school a little bit sort of lost and not knowing where I wanted to be, what kind of patients I wanted to see, what I wanted to do. And then as an intern, you had to do 2-month-long sets of night shift. So you're sort of alone in the hospital, and sometimes it's really busy and, everyone seems to be having issues, and sometimes there's not much going on. And it was in those sort of down moments that I started writing. And initially I focused more on memoir pieces. And then as I got more into neurology, I realized actually that's a great sort of way to interface writing with medicine, because there's so much that's unknown to the lay public about neurology. And there's also a lot of neurology in the news. And for the most part, it's really hard to digest unless you have sort of a ability to sort of understand the basic topics.
Mm-hmm. Yeah. When I first, way back when I first started doing my graduate education, so my undergrad is psych, my master's is neurobiology, and then I took a long time off and went back for clinical psych for my PhD. But I always attributed so much of my interest in psychology and neuroscience to Oliver Sacks. I read all of Oliver Sacks's books, I just inhaled them when I was younger. So I couldn't help but notice some similarities between these sort of bizarre and intriguing stories of times when the brain goes awry, but of course the digging deep into exactly what's going on and why does it happen. And I'm just curious, were you inspired by Oliver Sacks in any way? Have you read his work?
Yeah, I think 90% of the planets read his work.
I hope so.
Yeah, he really established this field of narrative neurology for non-neurologists. And he popularized this idea that it could be interesting for people without a medical degree to read about neurologic conditions. And it's sort of carried over into sort of other organ systems. So you have books about the heart, books about the lungs, but it really was established in neurology, I think, because it's neurologic conditions that actually change people's identities. You can have heart failure and that affects your quality of life. It affects what you can do, but you're still sort of the same person. Whereas neurologic diseases are so sort of curious and in some ways devastating because they actually change people's identities. And we grow up with this idea that our identity is us and that's sort of foundational and unchangeable. But when it comes to the brain, it's the one organ where that actually becomes, like, it's called into question. And I think that's why neurology lends itself so well to storytelling.
Absolutely. And so you are a cognitive neurologist. What was what did you specialize in as you were studying? Like, what specifically is cognitive neurology?
So most of what I see is patients who are coming in and they're reporting symptoms. And the question is this normal, or is this, is something going on in the brain that's neurodegenerative and progressive? And some of it is sort of typical things that you're probably imagining that you see in the movies, like putting the frying pan in the freezer, or forgetting what you had for dinner, 6 nights ago, or forgetting your, grandchild's name. But some of them are really atypical symptoms, like, someone who's been a very benign character and very measured, and suddenly they're looking at tons of pornography. They're buying, a convertible car without talking to their partner, and it causes terrible marital strife. And you go to, marriage therapy, and it's not effective. And it turns out it's actually a neurodegenerative process. Or people who come in and say, I started noticing I see things that I think aren't really there, and they're not threatening, but they look very real. Like I see a person sitting at the end of the bed sometimes, or I go to the kitchen and I think that there's a cat on the floor crawling around, even though I know I don't have a cat. So are these really sort of incredibly dramatic symptoms that we often hear about, and a lot of it is figuring out, what's going on at a molecular level in the person's brain. What's the real problem microscopically, even though we can't access the brain.
It's fascinating because, what I'm hearing is that a lot of your patients are coming to you and their chief complaint is, I think I'm losing my mind. Like, I'm afraid that I'm not who I was before. Am I losing my mind? Am I losing my memory? Am I losing my whatever? And this is a common thing that I see when I work with older adults in psychology. And I can imagine that the crossover between cognitive neurology and psychiatry as medical specialties must be large.
Oh, there's a huge overlap, and I actually think of a story of a patient a few years ago who came in and was talking to the patient and their spouse, and I said, "Have you ever done couples therapy?" And they said, "Well, not outside of what we do with you." And I was like, "I'm not actually technically a couples therapist, but so much of what we do is talking through the social implications of these diseases in partnerships. Because this is not a broken arm. But it's not, when people have these diseases, it's not something they're likely to recover from, at least with the treatments that we have today. And they affect people in relationships. And so there's so much navigating that has to be done in terms of how do partners sort of best respond to, and how do children and parents even best respond to a person's dementia or cognitive illness.
Yeah. Yeah. And so I'm curious, like, how would a patient know? Obviously, approaching it from the psychology side, like people go see psychologists when they have these questions. But from a medical perspective, how would a patient know if they need to see a neurologist or a psychiatrist or both?
So that's probably like one of the most common questions that we get. And a lot of it is these diseases often affect insight, and they can affect insight early on. So saying, you should just be aware of when you see a change is not that helpful, because in so many of these diseases, even if the disease is present, you won't notice a change. And so actually the better measure is to choose a sort of cognitive buddy. Choose someone that you trust. You can choose someone in your family or outside your family, whatever you like, and basically say to them, look, can you keep an eye on me? And if you notice that I look different from our peers, tell me. Because that's really the question is, am I changing more rapidly than what you see in normal aging? And do I look different than other people my age? Because you can imagine, someone who forgets a name and they're 75, the first thing their mind often goes to is, oh my gosh, it's the beginning of Alzheimer's disease. But actually, forgetting names is incredibly common in cognitively normal 75-year-olds. And so that line is so fine. And having another person who can say, look, I'm seeing this as becoming more significant, that's actually much more helpful than trying to figure it out yourself.
Yeah. That makes a lot of sense. It's, it can be really devastating for individuals. This sense of self, like you mentioned, we're talking about kind of a deeper philosophical question now, but like, what is self and what happens when self starts to feel shaky? It starts to feel fragmented. It starts to feel less reliable. It can be, for a lot of people, this is like their biggest fear. And so I can imagine that when you have patients coming in to see you, it's about a lot more than medical intervention. It's about like soulful, spiritual, psychological, humanistic intervention.
Yeah, so much of it is sort of, who am I in the presence of this disease? And what is left of my identity? And there's this sort of fear of losing the self. And it's also so much for caregivers is sort of this slow loss of a person in some ways. And it's sort of artfully described almost like as a robber. And, one night the robber comes in and takes a fork, and you don't really care because you have plenty of forks. And the next night they come and they take a cup, and you don't care because you have plenty of cups. But then before long, you realize you're actually missing half the kitchen. And it's just this sort of slow loss. And the other thing that I think is sort of the most poignant thing, that one person who is the wife of someone with a type of dementia called frontotemporal dementia, and she basically said, like, it's a slow grieving process. It's sort of ambiguous loss is the technical term that's been coined. And she sort of said, like, nobody brings a casserole by when your husband forgets your name. It's these very slow steps. So it's a completely different thing than losing someone abruptly.
Right. And so there's a lot of crossover. Maybe we start by focusing a little bit on dementia since you brought it up. There's a lot of crossover between different types of dementia, but they are, as far as we know, somewhat distinct. From what I remember, there are 4 types, right? Alzheimer's, vascular, frontotemporal, like you mentioned, and Lewy body dementia. Are there other types that I'm leaving out?
So those are some of the most common.
Oh, okay.
There are other sort of less common kinds of dementia, but those are sort of the big ones and the ones that you often hear. And the big differentiating thing is dementia basically just means you have trouble with sort of function. You can't pay the bills, you can't drive, or you can't, you have trouble grocery shopping. So you have actual functional impairment, and it's caused by difficulty with memory and thinking. And typically we mean it's caused by something progressive and neurodegenerative. So dementia.
Right. So there's a decline that you're seeing.
Exactly.
It didn't happen overnight after you bumped your head.
Exactly. So it has to be progressive. And the thought is, in general, that dementia basically just describes like what it looks like when someone moves about the world. So it's not that useful of a term. What you really want to know is what's going on in someone's brain at a microscopic level. And each of those terms, like frontotemporal dementia, Lewy body dementia, Alzheimer's disease, not as much vascular. But the first 3 really are references to microscopic findings.
Mm-hmm. And so when you say micro, you're talking like slides that you could take, let's say at autopsy, for example, and look under the microscope. So we're talking things at the cellular level.
So it's actually a protein level. So we're really saying, you can stain a slide to look for proteins, and do you see those abnormal proteins?
Right. And so really this is, to some extent, it's micro, but it's also, I guess, molecular. It's even smaller than that.
And molecular is probably a better name for it.
Yeah, of course, because that's how you titled your book.
I should take a lesson from my own book.
Yeah, so tell me about that. Tell me how you chose that title, and specifically, what is that molecule that you're referring to, that a molecule away from madness?
So I wanted to get at 2 concepts. One being sort of in some sense, sort of the fragility and the strength of the brain, in the sense that it's the most complex machine known to humankind. And yet there are these individual molecules that can essentially take down the entire machine. So it has these Achilles heels. It has these vulnerable points that we see over and over and over again in the population, where the brain just sort of completely malfunctions. So I wanted to bring that sort of dynamic to it. And then I also wanted to highlight where neurology is going in terms of cognitive neurology. Like, how are we actually going to get to cures for Alzheimer's disease, Lewy body disease, frontotemporal dementia? And the answer is we're going to get to cures at a molecular level. And this is a model taken from oncology, so taken from cancer studies, that part of the reason why we've been so effective in learning how to treat many, many cancers is because you take a piece of the cancer out and you look at it under a microscope and you figure out what molecules are abnormal, and then you take a medication off the shelf, and you use a medication that targets those molecules. That's where we're going with cognitive neurology. That's how we're going to get to an answer. And we've actually made enormous strides. And the reason why we haven't gotten to where cancer is. And the reason is that the brain is so inaccessible, or that's one of the big reasons that when someone comes into our office, I can't take a piece of their brain out and looking at it under a microscope. So you essentially have to find all these proxies to try to find what's going on at a molecular level without ever looking at it. And we've actually been more and more successful at doing that. And that's, I think that's where the answer is. That's how we're going to get to cures.
Well, and I'm hearing kind of like a downside and an upside here, kind of sticking with this cancer. I don't know if I want to call it an analogy, but this kind of cancer influence, because on the one hand, like you said, you can't really access the brain. Like with cancer, somebody has a scan, let's say they have a mammogram, they see something, you go in for a lumpectomy, or first you would go in for a biopsy. They actually have the tissue, the cancerous tissue itself, and they can test that cancerous tissue to determine what is the right drug. Does this have estrogen receptors? Does it have specific targets? And they can choose the right chemotherapy for that, or radiation, or they can just remove it with, and look at the margins, all of this stuff. When it comes to the brain, of course, that's sort of an option with brain cancer. But when we're talking about neurodegenerative diseases, we're not sampling individuals' brains, right? Which is why sometimes we can't even really confirm a diagnosis until
exactly. And
postmortem.
It's a horrible thought to say. You could say, look, I think this is the diagnosis, but I can't prove it until you die. It's a dramatic statement. And we actually now have gotten good at getting around that for some of these diseases, not for all of them, and we're not for many of them, but there's a few of them where we can be pretty sure about what's going on under a microscope without ever actually looking at the brain under a microscope.
Well, and this is the part that's like the upside that I'm thinking, because whereas the downside is we can't access the brain to test for these things, continuing with this cancer analogy, the upside is that, you tell me if I'm wrong here, but these different types of dementia are less personalized to the individual's biology. Like cancer, we're learning more and more. There's so many different types of cancer, and so much of that has to do with your own cell's behavior, what your own cells have, like which cells have decided to divide and how and why based on your specific genotype. Whereas with dementia, it's slightly more one size fits all, or am I wrong?
I don't know that I would agree with it.
I'm curious, because if we can't sample an individual and come up with a really tailored, targeted treatment for them, but we can say this is what happens in Alzheimer's. We're developing a treatment specific to Alzheimer's that hopefully we can give to anybody with Alzheimer's.
So the catch there, though, is how do we know someone has Alzheimer's disease? This is actually one of the stories you tell in the book is, how did that come to be? And it's sort of a wild story. So the original patient with the disease was this woman, August Dieter, and she was a housewife in Germany in the late 1800s. And she started getting confused. She would forget ingredients in recipes. She got confused around her own apartment. She had trouble finding her way around. She developed some paranoia. So she would hide things in the apartment, and then she would think that people had stolen them. She thought her husband was having an affair with the neighbor, even though there was apparently no evidence. And her husband ultimately said, couldn't deal with her behavior changes, and brought her to their doctor. And the doctor said, pack her things and bring her to the asylum. And he drops her off at this asylum in Frankfurt. And she never gets out alive. She was 51 at the time. And the next day she meets Alois Alzheimer, the original guy. And he was an incredible character. He was brilliant. He'd gone to a great medical school. He had written a PhD on the cellular life of earwax. And he was very sociable. So he also had a citation for disturbing the peace. And so he meets August Dieter, and he quickly realizes she's an unusual character. So she, he brings a bunch of objects to her and says, what's this? And she can name all of them. This is a pen, this is something else, this is something else. But as soon as he takes the objects away, she has no clue that he's shown her anything. And he says, can you write your name? And she writes Mrs., and then she forgets the task. And the reason that was so unusual is she was only 51. So people had seen senile dementia, but she was so young. And so that was why Alzheimer's was just sort of profoundly interested in her case. And he did what they did at the time. So they prescribed sedatives and water baths, which we know obviously, are not effective. And he ultimately moves away a little over a year later after his own wife passes away. But he basically calls dibs on her brain. So it's known around the asylum in Frankfurt that when this woman, August Dieter, dies, Alzheimer is going to get her brain in his new laboratory in Munich. And she dies in 1906, and the intern calls up Alzheimer in his lab and says, do you want me to send you her brain? And he says, sure, that would be great. And so, there's no consent at all at the time. He just fixes her brain and includes the brain in her entire medical file and sends it off to Alzheimer in Munich. And Alzheimer, at that point, he was this sort of very well-established neuropathologist or microscopist. So his skill is staining tissue and looking at it under a microscope. And so he does this with August Dieter's brain, and he sees these sort of structures, and they've been seen before, but they're never in this amount. So he basically sees two structures. One we now call tangles, and it almost looks like spaghetti inside of neurons. It's these sort of stringy-like structures. And the other we now call plaques. And it's almost like, if you can imagine like a spot of spray paint, it basically looks like that. And it's in the supportive cells of the brain. So it's not in neurons themselves. It's outside of the neurons. And people had seen those in senile dementia, but there wasn't that much of it. And Alzheimer's notices in this woman's brain that there's just a huge, huge amount of those tangles and plaques. And interestingly, he actually goes to present it at a meeting, and there's like complete silence in the background, and no one seems to care. And the moderator says, there's apparently no interest in discussion. Could you have a seat, please? And later in the meeting,
too early, yeah,
right, exactly. It was before his time.
Yeah.
But the highlight of that meeting, where he first presented this case, was a discussion about excessive masturbation, and the crowd went wild. Apparently, that was like the highlight of everyone's time there. And so the sort of reveal of Alzheimer's disease didn't get its due at the time, but eventually, it got recognition and so on. And we know now that those tangles, those spaghetti-like structures, are made of a protein called tau, and the plaques that look like that spot of spray paint is made of a protein called amyloid, and that's what defines the disease. It's buildup of amyloid and tau. For a very long time, we basically couldn't figure out if anyone had amyloid and tau in their brain. So we would say, they look like they have dementia, looks kind of like what we see in Alzheimer's disease, but we couldn't prove it. And so about 20% of people who were enrolled in trials for Alzheimer's disease didn't have the disease. And you can imagine, if you're trying to study, does a cast work for a broken arm, and 20% of the people in your study have a broken leg, you're never going to be able to figure out if it works or not. But that's now changed. So we actually now can diagnose Alzheimer's disease with relatively pretty good, certainty in life. But we haven't got there in the other dementias. We're not as good. But Alzheimer's disease, with sort of tests that are somewhat invasive or very, very expensive, so it's not an ideal situation. But we actually can get pretty good at diagnosing Alzheimer's disease in living people.
Yeah. Okay. And so this is was Alzheimer's sort of the first named dementia? I should say the first specific dementia that we understood?
It's a great question. I'm trying to think. So there's one called Creutzfeldt-Jakob disease that I wrote about in the book.
Right.
But that was coined, I want to say, in the 1920s, so a little bit later.
But that's so specific too. That's yes, I guess dementia is part of the feature of that disease, but that's like a prion disease, right?
Exactly. So it's a really unusual biochemical mechanism. It was it's a wild story, yeah, but it essentially goes back to Papua New Guinea in the mid 1950s was when it first sort of started coming to light. But it was a disease called kuru that actually probably started in the early 1900s in Papua New Guinea. And it spread in particular in this tribe called the Four tribe. And it caused mostly women and children to have this rapid decline where they would die within the year. And they would get unsteady. They would have this sort of uncontrollable laughter. And they would have cognitive impairment. They would have dementia. And no one could figure out what was causing it. And it was this sort of Estonian-born physician who was with the Australian Health Services. And he was stationed in Papua New Guinea at the time. And he started going out into the highlands and seeing people with the disease. And eventually he, along with a colleague, started collecting brains from people who had died from that disease. And he sort of sent them all over the world to say, like, can you help us? We have no idea what's causing this. And he got help in particular from two places. One was from a neuropathologist who said, actually, under a microscope, that looks like this other disease. This neuropathologist said, actually, this disease kuru looks like this other disease we know about called Creutzfeldt-Jakob disease. And the other place they got help from was a veterinarian who studied sheep. And he said, actually, this looks a lot like this disease I study in sheep. And they sort of put all the information together, and eventually they categorize all these diseases as called spongiform encephalopathies, because under a microscope, it literally looks like the brain has turned to a sponge. It has these holes, and that's because of the way that the tissue is treated to make those slides. And eventually in the 1980s, this guy, Stanley Prusiner, developed this theory that was at first widely rejected, that these diseases were caused by proteins that are essentially infectious.
Right.
So this term,
such a weird concept.
It's a totally weird concept because proteins, they can't replicate. So it's like, how does the disease spread? Yeah, so he got tons of pushback, but ultimately it's proven true that that's how these diseases, that's how they propagate. And kuru, that disease in Papua New Guinea, the reason why it was spreading is because that tribe had a tradition of what's called endocannibalism. So they would eat their own members. And in the funeral process, it was the women that would eat the brain. And then if there was extra, they would come home and give it to their kids. And that's why it affected women and kids. And once they figured it out, cannibalism was outlawed, and it's now essentially kuru's gone.
But that's also how we see mad cow spread and these other kind of animal diseases, right? It's that they're somehow consuming these misfolded proteins, and you can't like kill them by cooking it.
Yeah, they're incredibly resilient, and they also don't get killed by the typical sort of autoclave in a hospital. So there are stories of people getting electrodes implanted for testing for seizures, and it gets stuck on the electrodes, and then they clean the electrodes, they autoclave them, but the prions don't get killed, and they implant it in someone else, and the other person eventually develops the disease. Horrible. Or they've had it in corneal transplants. So there are these sort of horrible stories of outbreaks like that. And the best analogy that I read was basically that you can sort of imagine it if you have a room full of mouse traps and one of the traps goes off, it's going to propagate. They all will go off. And it's basically the same concept.
Oh, yeah, that's an interesting way to put it. And so, but Creutzfeldt-Jakob is specifically, it's a heritable disease, right?
So most of the time it's not. There is an heritable version.
Okay, I guess we think about that because we think about the genetic testing within Ashkenazi families and how they need to be screened for it, but it's usually not heritable?
Usually it's not. There are cases it is. And to be honest, most cases where we see it, we offer genetic testing because it changes things. If we find a genetic mutation, it changes things dramatically. But most of the time you don't.
Oh, I didn't know that. Interesting. Two very extreme ends, although somewhat similar, not completely similar presentations, but the dementia component is there in both of these examples that you just gave. This one of these plaques and tangles developing, and Alzheimer's, which is like incredibly common, and like the rate of Alzheimer's increases the older, your risk factors, I guess, or however you want to put it.
Age is the biggest sort of non-modifiable risk factor.
Right. The older you are, the more likely you are to get it. And then you've got the complete other end of the spectrum, which is these different spongiform encephalopathies, mad cow disease, the one in sheep, what's it called?
Scrapey, yeah.
Scrapey. Creutzfeldt-Jakob, Kuru, like all these different prion diseases, totally different mechanism in the brain, but is one of them the features that I'm hearing that dementia is global. Like part of the problem of dementia is that a lot is happening all over your brain.
Yeah, and I think that really highlights what we often end up talking to patients about, which is at the end, they all look the same. At the end, in the severe stages, all these look the same. The key to diagnosing dementia really is in the early symptoms, because the early symptoms tend to differ. But in the end stages, it all really looks the same.
And so it looks the same behaviorally, but their brains, like globally,
right.
their brains
not
look
under a microscope. Exactly.
Right. Under a microscope, they look wildly different. But I'm curious, sort of from a more macro scale, you do see similar features in their brains, right? You see like shrinkage of gray matter. You see like larger,
right. The vast majority of them, you see atrophy or shrinking of the brain. But oftentimes you'll see it in different places for different kinds of dementia. So there are certain patterns. So like Alzheimer's disease, classically, you see shrinking of what's called the hippocampi, which are the memory structures. So if you can imagine drawing a line from ear to ear, about a third of the way in on each side, you have a hippocampus. And that's what helps you remember things on the order from sort of a few minutes to, weeks and until it goes into your long-term memory. And so that typically gets small in Alzheimer's disease, well, not always. And you also often see atrophy or shrinking in the parietal lobe, sort of in the back of the brain at the top in Alzheimer's disease. Whereas in something like frontotemporal dementia, more typically you see atrophy or shrinking in the front of the brain. Lewy body disease, sometimes actually the volume looks completely normal. But it's not, the brain's not functioning normally, but the volume may be totally normal.
And so I'm curious about frontotemporal dementia because we haven't really talked about that much. Like it's got this very particular course. And like when you're looking at the growth structures of the brain, it's frontal lobe and temporal, the temporal lobe. But what's happening at the cellular level that makes it distinct from Alzheimer's or Lewy body, for example?
Yeah, so frontotemporal dementia in particular is interesting because it's not all the same. So Alzheimer's disease, it's always amyloid and tau. That's what defines the disease. But in frontotemporal dementia, sometimes it's a sort of a different form of the tau protein, which is always confusing for patients.
Oh, wow.
It's the same name, different form. And sometimes it's built up of a protein called TDP43. And we're not great in most cases at figuring out which protein is building up in a person's brain. With Alzheimer's disease, we have these tests where we can sort of figure out if there's amyloid and tau proteins while someone's living. With frontotemporal dementia, we really don't have the tools yet. And so part of the research studies that we do is trying to figure out, how can we actually identify this disease at a molecular level before someone dies?
How do we even know if there are proteins present? Like, do they build up to the point where you can see them on like a scan?
So it depends on the protein. So something like for amyloid and tau proteins, there are great scans for it. So we can have someone come in and you give them a injection of a tracer that sticks to amyloid or amyloid beta, and you can give them an injection of a tracer that sticks to tau, and then you take a picture of their brain and you can see, did the tracer stick or it didn't stick? And if it stuck, then we know, they have elevated amyloid or they have elevated tau. But that doesn't exist for most other forms of dementia. So for Lewy body disease, we don't have something like that. There is a test for Lewy body disease that uses spinal fluid that's sort of getting close to being ready to be used clinically. It's not quite there, but it actually relies on some of the same sort of principles as prion diseases.
Okay. And so for that, you would have to undergo a lumbar puncture.
Exactly. So
to be diagnosed.
Invasive. They're not nearly as bad as whatever it always imagined. So I do, at least one a week. So they're more benign than what people think of, but it's still invasive.
Right. So with Lewy body dementia, we haven't really gotten too deep into that. Like, what is a Lewy body? Like, obviously it's in the name. So what is the defining feature?
So essentially what you see is buildup of a protein called alpha-synuclein. And it's actually the same protein that you see building up in Parkinson's disease. And the thought is that it's sort of Parkinson's disease and Lewy body disease are on a spectrum. So one sort of differentiation that we use is if you have cognitive symptoms within a year of developing the motor stuff, so within a year of developing the slowness and the rigidity and the tremors of Parkinson's disease, if the cognitive symptoms develop within that first year, then we call it Lewy body disease. If not, then Parkinson's disease. But it gets a little more murky because there's also sort of official criteria for Lewy body disease. What you often see is these well-formed hallucinations. So those are the people who say, I'm seeing a person at the, sitting on the end of my bed, even though I know they're not there. Or we'll have people come in and say, have partners come in and say, I told them to set the table for dinner. And even though it's just the two of us in the house, they set the table for 3 people because they're seeing another person there. Yeah. And the answer is always, okay, let them set the table. That's totally fine. You don't have to correct them. Yeah. But it's sort of these wild sort of interfaces of reality and hallucination. And people with Lewy body disease also, they have the sort of Parkinsonian movements, that slowness. And then they tend to have a much higher rate of having what's called REM sleep behavior disorder. So normally when you're dreaming, part of your brainstem prevents your body from moving. And that's why you don't, if you're dreaming that you're running from a bear, you don't actually run off the bed. But some people do. And that actually can be a early sort of a risk factor for developing Lewy body disease. And the other thing that's sort of wild that we see sort of in clinic is they'll have what's called fluctuations in attention. So essentially, they may be totally on and with you, and then they just sort of space out for a minute or two. And then they come back. Or sometimes you'll hear they take these like extraordinarily long naps during the day. They just can't seem to stay awake. And other times they're, really seem to be alert and interactive. So it's just these sort of dramatic fluctuations that sometimes people think are actually strokes. So it's sort of it's a relatively common disease, but has some unusual features.
Absolutely. Yeah. I mean, it seems like clinically, some of these might be easier to differentiate based on these specific features if they are well defined, if they are sort of the chief complaint that these individuals are coming in with. But then, of course, there's vascular dementia, which is like a totally different animal than these other 3 that really do have this like deep kind of molecular basis.
Yeah. And so when it comes to vascular dementia, it's in some ways like all bets are off because you can have a stroke in any part of the brain that can almost do anything. So it can be really hard to sort of figure out how do you navigate, in particular also, how do you navigate vascular dementia or vascular disease in the presence of another type of dementia? Because you often see them together. So it really can have a very variable course.
And vascular dementia is not always just like a large stroke in one part of the brain. A lot of times it's these little tiny leaks, these little tiny blockages all over the brain, right?
Exactly. Right. They're sort of the classic textbook description is sort of a stepwise decline. But in reality, that's not by any means what we often see.
Right. Because, of course, people who have risk factors for this more global vascular problem, like mini strokes, are also have the exact same risk factors for larger strokes.
Right. So they have sort of, most people, right, they have risk factors for sort of damage to those small blood vessels in the brain. But oftentimes, you may have vascular disease and Alzheimer's disease.
Right, right.
And so there's just an enormous amount of copathology, which also makes it harder to study these diseases.
And so I'm curious about interventions then, because obviously there are plenty of behavioral interventions. There's, medical and psychoeducational interventions for caretakers and for family members. But there are some drugs, but there's been kind of a storied, even in the news recently, there's been a very storied kind of checkered past to some of these dementia drugs. And like, do they work? Do they not work? When do they work? What is, do they work with this type, but not with this other type? So I'm curious how you treat individuals who come in with these varied illnesses.
Yeah. So, the big story that's been in the news is about lecanemab, which is this drug that cleans up amyloid, which is one of the proteins that builds up in Alzheimer's disease. And the idea has been that if we can get rid of amyloid, maybe we can stop or cure the disease. And that's based on the fact. It's based on a few things, but one is amyloid builds up in the brain about 10 to 15 years before you actually even have symptoms of Alzheimer's disease. So by the time you have symptoms, you have amyloid all over the brain, basically. And we also know that some of the genes that sort of are individually cause Alzheimer's disease, most of them are associated with problems with amyloid. So that's been the idea for decades. And we've studied lots of drugs that get rid of amyloid, and they essentially universally don't work in clinic. So the trials all fail, except for these sort of latest amyloid cleansers that are more powerful than any of the ones we've had before. And the most recent story is this drug lecanemab, which is very clear that it cleans up amyloid. So if you give someone lecanemab, if you check and they have amyloid in the brain and you give them lecanemab, after a certain amount of time, if you check again, the amyloid is essentially much removed or significantly decreased. The question that really is at hand for us is, does that actually make a clinical difference in people's lives? And the study that they did, it was over a year and a half, and they found that the people who got the drug still declined, but they declined a little bit less than the people who didn't get the drug. And there's one question is, how much of a sort of beneficial effect do you need for a drug like that for it to be meaningful to someone in everyday life? If I told you that you would be able to remember an extra item on a grocery list because of this drug, would that be worth it? How much better do you need for a drug to be worth it? And that's
well, and also what are the risks of the drug?
Right.
Because with something that's declining that has no cure, I can imagine that a lot of people's view is, let's throw everything that we have at it, even if it is 1% effective. But if it causes great risk, then that becomes a more complicated calculus.
Yes, right. So it's sort of, there's the one attitude of, what do we have to lose? But then there's also, it can cause brain swelling, it can cause bleeding, and there were some deaths, that we think are related to the drug. And ultimately, our thought is, if we have, right now it's sort of a non-issue because it got this accelerated approval, which it's not full approval. It's not really covered by any insurances. But ultimately, if it gets full approval and it gets covered by insurance, the general thought is for people who look exactly like the population that was included in the study. They have mild symptoms or mild dementia. Their testing is relatively good. They're not like on a blood thinner. They're not at increased risk for bleeding. It would be reasonable to use a drug like that, but with the caveat that, we're not 100% convinced that the effect size is worth it, given the side effects. And also the other side effect is it's an infusion every 2 weeks. So if you think about a lot of Alzheimer's disease, a lot of the goal is really for it to be in the background, for people not to be sort of reminded of the disease all the time. But if you're going in for an infusion twice a month, it's really on the forefront. The question is it going to make people feel sick? Not sick, physically, but is it going to make them feel like they're an ill person? And what's sort of the psychological ramifications on being on a drug that's that invasive?
So tell me about that mentality, that sort of approach of like normalizing individuals and basically not pointing out their pathology constantly, because I think this is a common problem for caretakers or even just the general public, the non-caretakers, to get used to. Like, mom, remember, blah, blah, blah. Mom, no, that's not how you do that. Like this constant need to correct, which can actually cause a lot of mood problems, like a lot of frustration and even potentially, quote unquote, I hate this word, but quote unquote, aggression.
Yes, really. That's where the psychologists come in.
Right.
That's exactly it. And the general rule of thumb that we tell folks is, essentially, if it's not dangerous, don't correct them. So, if they think that their dead mother is coming for dinner, let them set the table. By all means, that's completely fine. And the other thing is, you can try to use distractions, but outright saying, that's wrong. Outright saying, that's a crazy idea. Why do you think that? That just makes people agitated. If you can imagine, if you thought that, your aunt was coming to dinner and someone told you that your aunt had died 20 years ago, you'd be like, that's crazy. I don't know what they're talking about. And so, you have to join someone's reality, and correcting them and trying to bring them into the truth only matters if it's like they're doing something unsafe.
But there's definitely this pervasive, I see it so often where there's like a real pushback saying, no, we have to correct this behavior because if we don't, and it's like, there's just this real lack of understanding that like, this is happening. You can't talk somebody out of this. This is their reality. And no matter how much pushback you give them, you can't, strong arm them into not having dementia. And I think it's a really hard thing for people to accept. And that kind of denial about it really sets in, but it can cause an awful lot of conflict.
Yes. I think part of it also is, and part of the word we use for some of it is sort of empathic lying. It's sort of you come up with another reason why you need someone to do something that's not related to their dementia, but you're not being totally truthful. And particularly for partners, there's a loss of empathy when you're constantly lying to your partner. And even though it's better for the person, but there's a loss of, not a loss of empathy, but a loss of intimacy. It's just sort of in some sense, it puts distance between you and the partner because you have all these thoughts that you can't share with them. And that's really hard for people, even though it's the best for the person with dementia. It's really hard.
Yeah. And I mean, I think that's why that we can clearly categorize dementia as a life-limiting illness. But one of the things that we probably don't talk about enough, and this is where my own bias coming from my own area of like research and clinical interest comes in, is the fact that these are degenerative diseases, meaning that ultimately these individuals will die from these diseases if they don't die from something else first. So is that part of the conversation common with you, with your patients, like really preparing for what that decline and ultimately what the end looks like?
Yes, I mean, so much of it is saying like, what's the future going to look like? In some ways, for diseases where there's no cure, that's really the big benefit of getting a diagnosis, because this allows us to say, look, this is how fast this disease typically progresses. This is what to do financially. These are the areas where people get in trouble in terms of safety. These are the things that slow down the disease, even though they don't stop them. But yeah, so much of it is talking about, what do we think is going to happen in the future? Because you can imagine, if you're financially preparing to be cognitively normal till age 90, that looks very different than if you're going to need full-time care for 10 years between your 60s and 70s.
Yeah. Yeah. And these different stages, like there is a very particular course to different types of dementia, right? Like there's the pre-dementia stage and then the early, the intermediate, the late stages. And they follow, I mean, not perfect, but they follow somewhat predictable patterns, right?
Yeah, there are sort of staging systems, and there's a few different ones that are out there. But yeah, once we figure out what disease we think is happening, once we sort of can figure out, okay, we think this is the likely molecular diagnosis, even though most of the time we can't prove it, that gives us a big leg up in terms of saying, like, these are the symptoms that are probably going to happen. So we know if it's someone with frontotemporal dementia, we know to say, look, they oftentimes have difficulty with incontinence much earlier than someone with Alzheimer's disease. So we're able to talk to people, talk to family members about, having a lower threshold to, call us when they notice stuff like that. So having the actual diagnosis of what type of dementia we think it is allows us a lot better to guide people along that path.
Yeah, I'm curious about, we talked a little bit about intervention, but I'd like to come back to intervention a little bit, that like basically what's on the market today doesn't cure this, right? It's may slow progression.
Right. For the vast majority of these diseases, there is no cure. Most of the diseases I write about in the book actually are curable. But for the common
Okay.
ones,
Yeah.
right, for these common ones that we're talking about, there's no cure. There's no magic bullet. There's not a way to reverse what's been done. And there's not a way to stop the progression.
Right. So a lot of what you're tasked with as a medical provider is having that therapeutic, that psychological mindset of like helping navigate with people the fact that we are preparing for something that's inevitable. We're not actually trying to fight this thing. We are trying to improve quality of life for as long as possible.
Right. So the main thing is, how do we, and what I often sort of talk about is like, how do you find joy after a diagnosis like this? And so I think people have this idea of, you get a diagnosis of Alzheimer's disease. Is there no happiness after that? And that's, there's plenty of happiness after a diagnosis of Alzheimer's disease. And how do we find that? What do people enjoy doing? And the other piece is we do know there are some things that slow things down. So we know that exercise tends to be associated with a slower course of decline, or social engagement or intellectual engagement. So we have some actual, we cannot stop it. We can't stop it from declining completely, but we do have some control over it.
So tell me about some of these like more curious causes for dementia-like symptoms that you chose to write about in your book that are reversible, that are treatable, so long as the medical professionals are able to wear their detective hats and figure out what the heck is going on.
Yeah. So there's a lot actually. Yeah, so the majority of the ones in the book are reversible. One of the stories is about a woman who grew up in sort of adverse circumstances, and her mom valued education, so she moved to this town, worked 2 jobs so that her daughter could be in a good school system. And I call the daughter Lauren Kane in the book. And so she grows up and she does beautifully in high school, gets into this elite college, and wants to become a writer. And she graduates from the college, goes home in 2016, and is at her mom's house working on like applications for graduate schools in writing. And she wakes up one morning that summer. She's been sort of binge watching The Walking Dead that summer, which was sort of the hot thing in 2016. And she wakes up one morning and goes down, has breakfast with her mom, and says, like, I'm feeling a little sleepy, and goes back to sleep. And an hour later, she wakes up again and says, what's for breakfast? And her mom's a little bit, she's sort of like, we just had breakfast. But Lauren goes back to sleep again, wakes up again, and says the same question, what's for breakfast? So she doesn't really seem to be, sort of retaining new information. And later the same day, she gets a fever. She starts getting sort of imbalanced on her feet. And her mom helps her to the car and takes her to the emergency room. And in the emergency room, the doctor comes in, starts asking her questions like, what state are we in? Can you count backwards from 100? And in the middle of questioning, she basically attacks the doctor, throws him to the floor. Her mom goes up to help her, and she throws her mom to the floor. She digs her fingernails into one of the nurse's arms, and they end up getting 9 security guards into the room to try to calm her down. And she starts calling people by these names. And she starts saying, like, I think he's a walker. And one of the security guards says, I think she thinks that she's like living in The Walking Dead. And he says, is she on PCP? And so she gets admitted to the hospital and ends up getting transferred to another hospital, where they actually finally figure out a diagnosis that her mom actually found by reading online. Her mom's very sort of health literate, and her mom read the story about young women who become psychotic. And it turns out it's caused by an immune process where there's antibodies that attack neurons. And her mom really sort of fought for her to get tested for this disease. And ultimately, she was totally correct. That was what was going on. And so Lauren Kane actually had antibodies that were attacking, that sort of inadvertently attacked neurons. And the mechanism of these antibodies actually it works the same essentially as PCP. So that guard in the security, that security guard in the emergency room actually was totally molecularly correct. It looked like she was on PCP. She hadn't actually ingested PCP.
No, she was on endogenous PCP. Oh no!
It was like she's on a drip of PCP.
Wow.
And they actually figured out that she sort of had what 50% of people with this condition have, where she actually had a small tumor on her ovary. And the tumor sort of masqueraded a little bit like nerve cells. And so her body tried to attack the tumor to get rid of it and created antibodies that attacked the molecules on this tumor. But because the tumor looked a bit like nerve cells, it created antibodies that actually attacked receptors that are critical for nerve cells. And that's why she basically was dissociating. So she was basically living in her own sort of mind and couldn't interface with reality. That's why it was this sort of memory of The Walking Dead that came up. She also had other things that she'd been into at the time. Her cat had just died, and she started having these sort of images of thinking that people were the cat. So it was a sort of really a dissociative experience, but it was not caused by sort of by PCP. It was just endogenous, and they eventually took the tumor out. They gave her immune suppressants, and she's back to normal. Yeah,
completely. So there's no lasting damage from attacking those cells.
There's the trauma of having a disease like that, but molecularly, she's treated, and she's molecularly cured. There's a risk of relapse, but usually when people relapse, people know what to look for this time. So you get
for sure. Yeah. Like at the earliest inkling, they're going to take themselves in.
Exactly.
That's fascinating. Yeah. That must not be a very how common is that?
It's people are realizing it's more common than we initially thought, but it is still rare. It was the first of its kind to be discovered in sort of, I think it was 2006, 2007 or so. So like 20 years ago, she would have been, admitted into an inpatient psych unit and never would have gotten out alive. But now that disease, and then actually there's been now a slew of other diseases that also are autoimmune diseases where they attack the brain. A ton of other diseases that are similar to that have now been discovered. And so you have all these people who were untreatable and essentially undiagnosable before, and now you can diagnose and treat them. You can totally cure them.
Well, this is fascinating because I feel like, coming from the psych side, we often hear about these like interesting, like Capgras delusion or these interesting, like psychiatric disorders where somebody feels like there are doubles, right? Or like you're a fake version, like you're invasion of the body snatchers of something. Or there's this other delusion where people think that they themselves are dead and they're like carrying, I can't remember what that one is called. I'm
Ooh, I don't know that
right
one. I have to look it up.
Delusion where you think you're dead. It also starts with a C. Cotard syndrome, also called walking corpse syndrome. And it makes me curious and they're really rare, and they're usually just kind of lumped into this like psychiatric, it's in the mind. Like, what even does that mean? I'd be so curious to see if these are not other kind of, yes, we call them delusions, but dementias, or things where there is an immune component. I don't know. That's fascinating. There's so many diseases out there that we probably still don't really get what's going on in the brain.
Totally. And they're actually the Capgras ones, just is the ones where you think that essentially you think someone's an imposter. And usually it's a loved one. So usually it's like you turn over in bed and you look at your wife and you think that they're a imposter. And that one actually you can sometimes see that can be the first symptom of Lewy body disease. So the hallucinations actually can be, either they can be very neurologically based.
Interesting. Oh, wow. That's fascinating. So much yet to understand, so much crossover. But of course, you present a sort of good spectrum within your book from the mundane to the bizarre. And it's I do think it's so important for individuals to at least be aware, both because there's just a fundamental curiosity about how our brains work, who we are, and kind of what can go awry. But also it is important to become aware of what to look for, if we do see signs or symptoms, and not to ignore them, because the earlier the diagnosis, like you mentioned, the best potential outcome for like a longer life and more quality of life during the time that these individuals have. I'm curious, Sara, I always close my shows by asking my guests the same two questions. And before we get to that part, I'm wondering if there's anything, I mean, there's so much that we didn't cover, obviously, but if there's anything that really sticks out to you that you feel like, we'd be remiss if we didn't mention this.
I think we covered a good balance of sort of the book and my everyday life also. So this is such a shame. These are all my favorite things to talk about.
I love it. All right. Well, here is one more thing that may or may not be your favorite. So just to give you a heads up, I always close my show by asking my guests the same two questions, because my guests come from all different walks of life and different fields. And so I'm super curious about their perspectives on these questions. They're kind of big picture, so apologies in advance. And if you need some time to think, no worries. But what I want you to do is think about the future. And you can think about the future in whatever context feels relevant to you. It can be personal, it can be professional, it can be community, it can be national, global, even cosmic. So no rules, really. So the first question is, when you think about the future, what is the thing that keeps you up the most at night, that you're most concerned about? Maybe you're even feeling a bit pessimistic or cynical about. And then on the flip side of that, so we can end on a more positive note, where are you actually finding your hope, your optimism? What are you genuinely looking forward to?
I guess the thing that worries me the most is sort of, I have this idea that, we've made so much progress lately on neurodegenerative diseases, and we seem like we're just on the cusp of making sort of huge strides. But sometimes I worry, the people who started this field, went into this field 20 years ago, were they saying the same thing? Or, 40 years ago, were they saying the same thing? And is it sort of this false hope? Or I see a lot of progress and optimism, but, is it possible that that's what everyone's seen, and yet we don't have cures yet? And I think on the flip side is actually just the same thing, which is we can now diagnose Alzheimer's disease in living people. So we're like so much better at enrolling people in studies. And for Lewy body disease, we're sort of on the cusp of having a test that's clinically available or clinically useful for diagnosing Lewy body disease in people who are living. And so, and for frontotemporal dementia, maybe we'll get there pretty soon because we have more research on frontotemporal dementia now than we've had ever before. Yeah. And so I think on the positive side is there's just a enormous amount of data that's coming out. And there are lots and lots and lots of brilliant people who are working on this.
Absolutely. Well, everyone, the book is A Molecule Away from Madness, Tales of the Hijacked Brain by Dr. Sara Manning Peskin. Thank you so much for being here, Sara, and for teaching us so much about this really important aspect of who we are and what can go wrong and often does go wrong and how to kind of identify it.
Oh, thank you so much for having me. Thanks for indulging and talking about all these things that I like.
Oh, no, I love it. I'm right there with you. And everybody listening, thank you for coming back week after week. I'm really looking forward to the next time we all get together to talk nerdy.